Now I'd like to call upon Professor Ramesh Singh Bhandari. Professor Ramesh Singh Bhandari is the Professor and Head of Department of Surgical Gastroenterology at Institute of Medicine, TU Teaching Hospital. And he's talking about optimum surgery in chronic pancreatitis.
Optimum surgery in chronic pancreatitis. The recent landmark trial, the ESCAPE trial, which is a Dutch multicentric trial, has looked into the short-term and long-term outcomes of the early surgery in patients with chronic pancreatitis, and which has revealed the role of the early surgery in both the short-term and long-term outcomes, significant improvement in pain management in these patients. Besides this, the SCOPA trial from European multicentric, this is a prospective study, has also added this evidence. So these two are the strong evidence in the current time to support the role of early surgery in patients with chronic pancreatitis. So what would be the best surgery for these patients? While we decide, I think we need to take into consideration these important factors: whether the duct is dilated, non-dilated, if there's an inflammatory head mass, any suspicion of malignancy, and if the patient has developed any complications. So what are the surgical options? We have drainage procedures, we have resection procedures, and we have combination of these both procedures, what we call as hybrid procedures. Now, within the drainage procedures, the classically defined Duval and Pusto's procedures, but these are not done frequently. And then what is followed by a modified Pusto's, which used to be a common surgery a few decades back. And the Izbiki procedure, which is essentially the resectional procedure where a V-shaped incision is made in the pancreas, especially in the non-dilated ducts. And the drainage this is more of a resection than a drainage procedure. So within a resection procedure, we have a pancreatitis, we have Beger's procedure where head coring is done and the pancreatic neck is transected, and we need to do 2 anastomosis, and then finally total pancreatectomy. Now, combining the principle of both these resection and drainage procedure, we have this bond modification of Beger's where the transection of the neck is not done. Then the most important and the most widely accepted procedure, what is called as Fraze procedure, and the Hamburg, which is more of a modified Izbiki procedure. Picturestically, it looks like a Fraze, but it's done in patients with non-dilated ducts, and it is more of a resectional procedure than more of the drainage procedure. So besides these factors I said to you, I think the most important thing that we need to consider is the technical complexity of these procedure. We want to do a less complex, at the same time it has to have a good long-term pain control. Now let's see, these preoperative factors can help us. If you have a head mass with suspicion of malignancy, I think the pancreatic duodenectomy is an ideal operation. Patients with head mass and dilated duct, we have options, Frey and other duodenal preserving sections like Beger and Bond. If it's a head mass with a small duct, then we have Hamburg, which is a modification of Izbiki. We can do pancreatic duodenectomy, we can do Beger, we can do Bond procedures. Okay, so there are so many options. Now, if there is dilated duct but no head mass, we could do Pusto's, or we can do modified Pusto's. Patients who have no head mass, no dilated ducts, Izbiki would be the only options left. And if it is a hereditary pancreatitis or grossly fibrotic pancreas, refractory chronic pancreatitis, I think it's a total pancreatectomy. Now, in a patients with head mass and dilated duct, so many options. The Beger procedure, if you see, here the Beger only course out in the head. You do transection of the neck, but the body and tail duct is not addressed. Similarly, Bond, which is essentially again a Beger posture, it does not address the body and tail. And these are against the principles of treating these patients with chronic pancreatitis. You need to address the pacemaker head, also you need to address the dilated duct in the body and tail. The pancreatic duodenectomy is will be too much for these benign conditions. And these Pusto's, modified Pusto's, will not address the head. So what left with us? It's the Fraze procedure that seems the best ideal for these patients. I looked into the comparison of Fraze along with these other important surgeries, the Beger's and pancreatic duodenectomy. What I found is essentially the pain control is okay, is similar with Fraze and these other complex procedures. But what to be noticed is the Fraze has much less complications, very less morbidity in comparison to these two other more complex surgeries. So I would say Fraze would be the best one for patients with head mass and a dilated pancreatic duct. In the patients who have a dilated duct and no head mass, what we have left? We could do a classical Duval's or Pusto's. We could do longitudinal pancreatitis, but the problem here is they are not addressing the head again. Again, the principle of management of chronic pancreatitis is we need to address the head. Even if there is no mass, we still need to do some coring of the pancreatic head to dismantle that pacemaker of the pen. So again, I think the phrase would be fine. You can drain the ducts and you can core out some of the tissues from the pancreatic head. So phrase would be ideal even in these situations. I looked into comparison of phrase and fused toes, and I found that in patients who have no head mass but a dilated pancreatic duct, if you just do a fused toes, there is a double the incidence of recurrence of pain in these patients. So what's the best? It's the phrase procedure again is best in patients with dilated duct and no head mass. So the phrase has been defined in many different ways. The classical phrase, what we call as original phrase, was a quite extensive coring reaching up to the level of the bile ducts. You could clear up to the bile duct, you core out all the tissues, although you left in the margins, you leave behind a good amount of tissues. Then came is a modified phrase, and I think that's what most of us are doing. We do core out, but we don't reach to the level of the duct. We only stay up to the posterior margin of the duct itself. And a minimum phrase where patients who do not have much of the head tissues, we just take out a small part of the pancreatic head, core out. That's what we call as minimum phrase. The comparison had been made, and there has not been much of a difference in between these minimum, modified, or original phrase. But having said that, there are reports which tells us that the more the head you core out, the more the chance that you control the pain bearer, but at the cost of increasing some complications. So we have to take these things into considerations. Okay, there are plenty of reports saying do the original phrase to control the pain. So what we have been doing, we usually, I think it's between the modified phrase and original phrase, but in most of the case, this is one of the picture. Thank you, Sampanna, for giving me this picture. I think what we do is we limit our coring up to the posterior margin of the open ducts. And we have seen, I think this has been helping us. A decade ago, I looked into the 19 patients of the series of 19 patients from our department. The phrase and the fused toes used to be, modified fused toes used to be the commonest surgical procedures that we used to do. And the recent times, the Nimes had published this from our department. In the series of these patients, now what we see is almost 90% of the patients are treated by phrase procedure. What I'm trying to say is the phrase is the most common procedure that is being done in patients with chronic pancreatitis, unless in patients who have malignancies. The Izbiki or a modified Izbiki, what is called as Hamburg procedure, has been defined for patients with a non-dilated ducts. So with this essentially is, again, I would say a resectional procedure where the V-shaped incision given in the pancreatic body and tail along the line of the duct, suspected duct. And if you extend this coring into the head, that becomes a Hamburg procedure. And the first report, it was come up by Izbiki as in STEAM after 13 patients. And they reported a very good outcome following these procedures. But unfortunately, we don't have enough other studies to support these Izbiki and Hamburg procedures. At the same time, these are very complex and technically challenging procedures. So we need to be finger crossed while we are opting for operating in patients with these procedures. The total pancreatectomy with islet autocell transplantation is an ideal procedure, especially in patients who are refractory chronic pancreatitis, and also patients who have genetic mutations. And there are series of these patients who have TPIATs and have shown good results in terms of both the pain control as well as good quality of life. But again, the problem is of the cost factor and the technicality and the availability of these service in every centers. So to end with my take-home message from my side, the patients who have head mass or no head mass, dilated duct, do phrase, head mass, non-dilated duct, pancreatitis, or we have other duodenal preserving procedures can be done. No head mass, no small duct, Izbiki or modification, we can do it, but be cautious while contemplating this procedure. Any suspicions, do pancreatitis, no confusion. And TPIAT, if you have it, you can do it, but because of limited availability and the cost factor, this is a limitation for using this surgical technique, this surgical procedure in our set of patients. Thank you all for a kind attention.